All right, we are going to go ahead and get started. It's right at 12 o'clock. So welcome to Medical Grand Rounds at the University of Colorado. Really good to see everyone here in Truffle Auditorium. Please come in person. I would love to see this room filled up, but thank you to the folks that are here. As a little bit of a teaser to get folks to show up in the next several weeks, next week we're really excited. We're going to welcome Dr. Kim Manning. A lot of you may know Dr. Manning from the lay press, from social media. She is a star. She'll be coming for the Mentorship Academy. Also will be Medical Grand Rounds. And then on November 1st, we're going to welcome Dr. Anne-Marie Schmidt from NYU, who's going to deliver the 2023 ECHL Distinguished Lectureship. As a reminder, there's CME and MOC credit for all talks this year. Feel free to scan that. And now I want to give at least a little bit of a welcome. She asked me not to do too much, but to our today's speaker, Dr. Jane Reusch. Dr. Reusch is a professor in the Division of Endocrinology, Metabolism, and Diabetes. She is the director of the Diabetes and Personalized Medicine Research to Transform Care Center. She's the associate director of the Center for Women's Health Research and the co-director of the University of Colorado NIH Diabetes Research Center. She did her undergrad work at Notre Dame, where she graduated cum laude. She was a medical student at Northwestern University and the University of Minnesota. And then we were lucky enough to, I will say, recruit her here a very long time ago as an intern and a resident in this residency program. She stayed here at the University of Colorado for her endocrinology fellowship and has done extensive post-training leadership work through the CCTSI, ELAM, and other leadership organizations. Dr. Reusch has been a leader on this campus, at the VA in particular, and nationally through her work with the NIH, the ADA, where she was president for a period of time, the Colorado Department of Health, the DOD, the AHA, really for the entirety of her career. She's a tireless educator, and many of you probably know her in that role if you're a medical student or house staff here, and also an incredibly well-funded researcher ever since her junior faculty years. Dr. Reusch is also an incredible mentor. She's successfully mentored 22 faculty members in the Division of Endocrinology, 21 fellows, and probably most impressively, she continues to mentor high school students as recently as this year through the GEMS program and others. She's incredibly giving of her time. Many of our faculty, and I know the residents certainly know her from her current 4-part NEJM double take series on type 2 diabetes, the 4th of which comes out this coming week. Dr. Reusch has listed several goals, and I'm going to read them off because I think this encapsulates what would be an otherwise very long CV to read through. Her goals are to improve the health of people who are at risk for diabetes through medical education, clinical care optimization, and advocacy for healthcare and research, to perform and disseminate cutting-edge translational research on the cardiometabolic complications of diabetes with a focus on sex differences, and to train and recruit and retain the biomedical research workforce, particularly physician scientists, with special attention to clinical and translational research in diabetes and the health of women. If there's any way to sum up her incredible career, I think that would be it. Really is a pleasure to welcome Dr. Jane Reusch.
Well, I want to thank everybody for the opportunity to be here today. Medical Grand Rounds, particularly the University of Colorado Medical Grand Rounds, it used to be all of us in one room back on the old campus. We were a smaller and kinder and gentler place. But now I don't know everyone in this room, but that does not mean that it's not my privilege to speak to you today. I chose a topic that may or may not appear to be of interest to all of you. I chose this topic because I want to show those of you in this room that you can arrive at the University of Colorado as a physician with very limited research experience and ask a big question and build a team to become a physician scientist. So my first disclosure is that I have the world's best job as a physician scientist. Now, you'll have to have other disclosures for CME and MOC, and that is all of the funding that has allowed me to do the work I'm going to show you today. Now, as a physician scientist, one of the very important things is to stumble on or find, while rounding in the hospital, an important question. And once you do that, you need to build a team of people around you in order to address that question. So as a researcher, before I ever start to tell you anything about the work that we do as a team, I have to tell you that this involves a huge group of people as well as our human and rodent participants. So I was a basic scientist for the first 10 years after joining the faculty. Sort of a curious thing for a physician with no background, but when I did my fellowship, I did one project that was bench science, insulin action. I did another project that was fasting, which is now all the rage, but in the early 1990s, everybody thought that was for the birds. And I fell in love with cell biology and signal transduction. But I was still clinically devoting myself to people with diabetes and to becoming a diabetologist. And Dr. Judy Regensteiner, director of the Ludeman Family Center for Women's Health Research, found me and said, I would like to do a study where we look at people with and without diabetes and see what is their functional exercise capacity, otherwise known as VO2 peak or VO2 max, throughout this talk. And what we found is that these relatively young women with diabetes had a functional capacity or a VO2 peak in the frailty range. This is kind of a big deal because frailty, we all know, is not good for you, but this actually becomes a big problem. And even after we did exercise training in these women, what we saw was that the women who had diabetes, once after a formal exercise training, still had the same level of fitness as women who had just obesity but not diabetes. Now, I could be a skeptic. I could say, I see my patients in clinic. They don't maximally exercise. Why do I care about whether they can maximally exercise? So around the same time we were doing this work, a number of epidemiologists were doing this work, where they would measure fitness at one day and then follow people over 10 to 15 years and see how well they did. And the people with the higher functional capacity, as we had kind of always known from oncology, have a lot higher likelihood of living over that next 15 years. And so that seemed like maybe this lack of function was an important problem that we should really try to get after. We then found that this problem was more severe in women, a 24% deficit compared to a 16% deficit in age similar men and women in the premenopausal range. And that we were seeing, in collaboration with Dr. Kristen Nadeau, a decrease in maximal exercise capacity in adolescents who were developing diabetes, type 1 and type 2. So we come to a situation where we have decreased functional exercise capacity in people with newly diagnosed diabetes, otherwise uncomplicated, adults and kids. This seems like it could be a big problem. And then more data began to emerge that cardiorespiratory fitness, no matter what your disease background, actually predicts an increased risk of death. So death, that's one of those hard endpoints in studies. It's not, do you feel a little better? It's death. All right. So we are now ready to say, this is an important problem and let's figure it out. So why would it be that exercise would be such a major risk factor for premature death? Well, if we think about what happens with exercise versus sedentarism, we can see, mitochondria, and I am a person who does a lot of work on mitochondria, but also the skeletal muscle, the heart, the arteries, they all respond negatively to sedentarism and positively to exercise. So when we think about an exercise stress test, it's integrative physiology in action, and it's maybe the ultimate vital sign. So why would I say that? Well, because if I'm checking my pulse ox and my heart rate and my blood pressure, all right, in the clinic, all right, but I don't know how it does when it's stressed. I may not know how somebody does in day-to-day life. Whereas exercise requires increased ventilation, oxygenation of hemoglobin, delivery to the heart and the skeletal muscle, and metabolism within the heart and the skeletal muscle. Seems like not only an important problem, but an interesting problem, and one that might require a physician, because a physician doesn't think in terms of one organ at a time, but that whole organism, the human. So our big question is, what are the physiological mechanisms that are leading to decreased exercise capacity? And when we say translational research, what we want to do is we want to go from the bedside with a big problem and to everything we can use, cells, animal models, human subjects, in order to get at the answer to that question. So what we've learned so far is that this defect or this impairment in exercise capacity correlates with insulin resistance, endothelial dysfunction, heart and skeletal muscle dysfunction. And what we've really been focused on recently is the way that blood flow is delivered to the heart and the skeletal muscle. Now, I want to know this, and what my holy grail is to find a pill for exercise or an exercise mimetic that doesn't mean you don't have to exercise. It means that when you do exercise, it will be really good for you from a brain, heart, cardiometabolic health, from every perspective. Will this work? Well, we had an early discovery that was so cool that I think it has propelled us through the next 20 years of fits and ties, all right? And that is that in our work with Dr. Nadeau, we were able to find that there was a very strong correlation. And see, this R or R squared value in humans is unheard of. All right, that's a crazy number, that relationship, that between the amount of exercise you're able to do and your insulin sensitivity, there is this very strong correlation. And then we go back to our physician superpower. Don't we have a drug for that? All right. And so that is why we need physicians doing science, right? And we say, yeah, I do have a drug for that. And it's a thiazolidinedione. So back before thiazolidinediones were made unpopular, and rosiglitazone specifically, it's a PPAR gamma receptor. If you're young enough that it's never been on the market, well, you've been a doctor, but it is like pioglitazone, all right? And what we found was crazy. In these people with diabetes, we gave them this rosiglitazone, 4 milligrams a day, that was a half a dose for 4 months. We improved their cardiorespiratory fitness. They gained 5 pounds, so it wasn't going to be something you're selling in the gym, but we were able to show also that the kinetics at the onset of exercise improved. But mainly what this did for us is it gave us the idea that if we identified the physiological and molecular underpinnings of this impairment, we could be able to come up with strategies to turn this impairment around. So then we sort of wanted to think about this as systemic adaptation. So exercise stress makes the body work. So I go back now to my molecular or cell biology routes, and I say, how does insulin action hold this story together? All right, so I think like a signaler, okay, cell signaling. In medical school, you thought maybe this was, something you had to learn, but not something you loved. Okay, you should love it. It's so fun, all right? But either way, insulin signals through a series of pathways, one of which is nitric oxide synthase. Exercise signals through a number of pathways, one of which is nitric oxide synthase. And Michael Kwan and others had long ago identified that in the vasculature, nitric oxide synthase is specifically dysfunctional in people with diabetes. So I thought, that could be cool. Well, turns out that I'm forgetting his name, anyhow, pediatric pulmonologist here on campus, had some enos null mice. So so I said, can I take a look at your mice and see how they exercise and what happens to their mitochondria? And so I'm going to show you some basic science. How many of you don't like that? Okay, well, all of you. Okay, I get it. All right, so what I'm going to show you is that if I look at, this is one protein from each of the subcomplexes of the electron transport chain. Now, everybody knows that we need it, but nobody wants to think about it. But anyhow, this is one protein from each of these. This is a little snapshot and you're going to see it a couple times. So a little snapshot of your electron transport capacity, a little snapshot of the upstream regulators of electron transport, and a little snapshot of some other darn thing that also regulates mitochondrial function. Now, what we saw in these mice that were either holodeficient or haplodeficient in eNOS was that they lost their mitochondrial content. And what we saw when we just blocked nitric oxide synthase, like happens in diabetes, was the same thing happened in the arteries. We also saw that we lost mitochondrial biogenesis and we lost antioxidant defense. Then we took these same animals where we had inhibited nitric oxide synthase in order to mimic diabetes, and we saw that if we didn't have nitric oxide synthase around, we should get improvement with exercise training in mitochondrial content and in their fusion and fission. And mitochondria, for those of you who don't know, are like it's really cool. They're not little footballs. They come in these big networks and they fuse and fizz all over the place. They're really fun to watch. I'm sorry, I'm just revealing the whole true nerd thing, but maybe you need that, right? Okay, and what we saw was when we mimicked diabetes, the mitochondria failed to respond and we didn't see the mitochondrial adaptation. So here we are again, we're saying, okay, nitric oxide synthase in impairment mimics diabetes. And once again, don't we have a drug for that? All right, so it's always good to be in diabetes, particularly in the last 20 years, because there's a lot of new drugs in the field of diabetes, one of which is the GLP-1 agents. Now, you're thinking of them in terms of weight loss, but when I was a cell biologist for 10 years, I studied a protein named CREB, and it is the cyclic AMP, response element binding protein, protein kinase A, cyclic nucleotides. Turns out that GLP-1 increases cyclic nucleotides and will upregulate nitric oxide synthase and blood flow to the heart and to the skeletal muscle. Let's give that a go. So Amy Keller in the lab gave animals, rats this time, saxagliptin. Saxagliptin is a DPP-4 inhibitor. It's going to increase endogenous circulating GLP-1. So this is the incretin that's secreted from the gut after a meal and that we're now treating diabetes with because it's an insulin secretagogue, and it also does a bunch of other cool things not relevant at this moment in time. All right. What it does, though, is it first reveals that rats are obnoxious. All right. I guess you all knew that, right? So, but one of the ways in which rats are obnoxious is that they can exercise train in 7 days. Okay, they can get an adaptive cardiac and vascular response to exercise training in 7 days. Really obnoxious, okay? And so if I treat these animals with saxagliptin and 7 days of exercise, I can see an increase in that exercise signaling pathway I showed you, AMP kinase, NOS, PGC1 alpha, whereas these control diabetes rats didn't get that good response. Similarly, this mitochondrial thing that you've just all been putting up with for the last little while is also improved. But you know, it's possible that you guys don't care that much about what's happening with mitochondria number, but you might want to know what's happening with exercise capacity. So when Amy Keller exercised these rats for 3 weeks, she saw about a 50% increase in their exercise capacity. And we wondered, is this happening via GLP-1? So we used a GLP-1 receptor antagonist, and Becky Scalzo was able to show that if you inhibit GLP-1 action with exercise training, you will decrease both basal and exercise training ability, but you will also have a deleterious effect on the heart. So in the presence of this GLP-1 receptor antagonist, you get left ventricular hypertrophy that is enhanced even in the context of exercise. You get increased pulse wave velocity, aka arterial stiffness. And then when we measure arterial stiffness with a little stretch strain model in collaboration with Kendall Hunter, we see that exercise training should improve central arterial stiffness. But these animals actually got worse. So we thought, okay, just like rosiglitazone, let's take this straight to the humans. We went straight to the humans, and what we found was that unlike insulin sensitization with the TZDs, GLP-1 alone, not combined with exercise because we weren't resourced for that, did not impact maximal exercise capacity. But it did impact heart function, LV strain, and it did improve central arterial stiffness. So, okay, we don't have the solution yet with a drug that isn't sort of thrown off the market, but let's keep looking at this. All right, so we want to try to disentangle what's happening at the skeletal muscle and what's happening at the heart. All right, we know that these two are important, and we also know that it's diabetes we're dealing with, and the central tenet abnormality in diabetes is endothelial or microvascular dysfunction. So let's look at that. And once again, it is time to think like a clinician. Okay, so here is exercise. Okay, the heart, the lungs, the muscle, all working together. And we want to study mechanism. So God bless her, Judy Regensteiner is really good at getting people to do things. And one of those things, so she gets me to do a lot of things, but one of those things is to convince participants that they would be willing to be in a clinical trial. So if I asked you, because many of you are premenopausal women, would you please, and you don't have diabetes or anything, would you please come to the Clinical Research Center, and I'm going to put in a right heart cath, and then I'm going to ask you to go up to the to exercise on a bike, and we're going to measure wedge pressure. How many of you would sign up? Okay. Yeah. Oh, okay. We have a couple takers. Okay. So thank you. We want you to be in all of our trials from now on. All right. But what happened is we did actually recruit these people, and what we showed is to a person, at this very low workload, we had a big increase in pulmonary capillary wedge pressure in the people with diabetes. And then I'm saying, hey, you know, they just got diabetes. I don't really believe that this is their heart muscle. Think like a clinician. How do we look at perfusion in the heart in our patients? Let's use some Sesame. So we got Rob Quaife on board, all right? And what we saw was astonishing. In this subset of people, they with the exercise challenge, they did not increase their perfusion. Their cardiac output was not significantly different, but this perfusion thing really captured our imagination. So I said, well, is the same thing going to be happening in the skeletal muscle? Okay, so we're going to look at blood flow to the skeletal muscle. And then in collaboration with Irene Schauer, Kristen Nadeau, and Melanie Cree-Green, what we were able to do was to measure oxidative flux through the skeletal muscle using a crazy cool MRI trick, all right? So in your muscle, you've got high energy phosphates. If you exercise that muscle, you will deplete those high energy phosphates. And then we can measure your oxidative flux by just letting you let your foot off that pedal. So what that looks like is this. You've depleted phosphocreatine, and we're watching it recover. And what we saw, and this is what other people had also previously seen, was that people with diabetes had low phosphocreatine turnover. I mean, low phosphocreatine production. Took them longer to turn over their ATP, and so they had decreased oxidative flux. Once again, I'm not convinced. This is a 90-second exercise. These people are walking around. They can walk around. I don't think they have a mitochondrial disease, although maybe diabetes is. And so what if we take advantage of the idea that we're at altitude? We just put some oxygen on them, okay? So what do oh, their mitochondria also on biopsy didn't look particularly abnormal, okay? So put some oxygen on them. We front load the system. We front load the system. I saw Mark look at his watch, so I'm gonna look at my watch. Okay, we front load the system, okay, with some oxygen, and we see something already unexpected. In terms of the oxygen tension, both in the people without and with diabetes, we see an improvement in the oxygenation in the skeletal muscle. But by this assay that we have, a cool little assay where we put a patch on the skin and we measure deoxyhemoglobin and oxyhemoglobin, what we ended up seeing was that there was increased perfusion. Now, if I put somebody on a maximal oxygen amount, they should actually decrease their perfusion, not increase their perfusion. Think about lungs, be a clinician, a pulmonologist, all right? So that already said that maybe there was some local muscle hypoxia in these people. But here's the crazy data. Just the people with type 2 diabetes, not the people with obesity alone, improved their phosphocreatine production, their oxidative phosphorylation, and their maximal oxidative capacity, suggesting that like in the heart, in the skeletal muscle, we had a perfusion defect. All right, so then in collaboration with Dr. Amy Hipsman and Mason McClatchy, we used near-infrared spectroscopy. And what this is oxyhemoglobin on one side, deoxyhemoglobin on another side, and we measure this while exercising. And what you'll see, the onset of exercise, you can see increased perfusion with our particular NIRS device, and decreased oxyhemoglobin and increased deoxyhemoglobin. All right, so that's what you should do. That's what you should see. All right, and it had been long established in exercise physiology that should just be a lovely relationship, not as strong of an R value, R squared here as the other, but pretty strong, a very strong relationship between VO2 peak and deoxyhemoglobin accumulation. But in the people with diabetes, that relationship was really just not there. All right, so this suggested that maybe we were seeing heterogeneous perfusion, and some capillaries would be running very quickly and not really unload their oxygen. Some would run very slowly and build up deoxyhemoglobin, which is going to come up again in a sec. So now we have this model, and we're pretty excited about it. So the question is, what do we call it? So you have to have your own name, right? So vascular metabolic inflexibility means I can only use fat, or I can only use carbohydrate, and I can't flex very much. So my new idea is that I have vascular inflexibility, so that in diabetes, when I put a demand on the system needing to exercise my heart and my skeletal muscle, they're not going to respond. So that's inflexible. All right. It hasn't caught on yet, but we'll give us some time. All right. But our model is that we've got this heterogeneous perfusion in the heart and the skeletal muscle, and there are probably other things happening as well. So can we reverse this new defect that we have identified? And so we have just finished up a VA study doing aerobic exercise training, and we have an ongoing animal study using nitrites, which I'm going to explain to you in a minute why that might work. So our VA study is to see if we identify heart, skeletal muscle, perfusion, and central arterial defects, can we then do exercise training? And will people with diabetes look different than people with obesity alone? And will men respond differently than women? All right, so here's the people, and we've got Judy, so we're convincing people to come in and be part of this study. All right. And we've learned we know a lot about these people. This is what we call clinical deep phenotyping. We know all of their sort of clinical parameters. And then we also know their insulin action from an insulin clamp, and we know their percent body fat and muscle mass from a DEXA. And we have identified relatively uncomplicated people with obesity versus diabetes. And here comes our first disappointment. Okay, and I'm not disappointed that people with diabetes aren't so sick, but what I learned was that in this early age group, it is really the obesity, not so much the diabetes, driving changes in cardiac structure, as well as and stroke volume, all right, and ejection fraction. So how about the central arterial stiffness that we talked about before? And we have lots of ways to look at this. We can look at it with MRI, we can look at it with tonometry, and we'll drive you crazy with our bioengineers. But what we found is that if we look at arterial stiffness, and we look at it compared to a lean control or registrant control cohort, obesity and diabetes are leading to arterial stiffness no matter how you measure it. But the difference between diabetes and obesity alone is only in this upswing of the heart. So if, it wasn't supposed to both come on at once. If I'm measuring pulse pressures, and I have my left ventricle, and then I go to the aorta, you can see how the aorta is dampening everything. But if I have increased pressures here in the central artery, that's going to feed back to the heart and to the skeletal muscle. And so what we think might be happening, because it was just that one little segment of the artery that was really different, but the heart was very different, that the ascending aorta is causing a pressure scenario that's building back on the heart, leading to that left ventricular remodeling. I don't know if it's true. We are doing a lot of interventions to see if we can make it go away, and we'll see. Okay, so this is a model that we came up with to represent this, to say that obesity is really driving some of these earliest changes in the heart and the vasculature, but that obesity together with type 2 diabetes is leading specifically to this ascending aorta abnormality. We also found in this study that there was that same heterogeneous tissue extraction that we had been seeing in our postmenopausal people, and that the sympathetic nervous system tone was specifically different even in these uncomplicated premenopausal age, and men obviously are not premenopausal, but age similar controls. So now I have the heart, I've got the blood flow, I've got the skeletal muscle. This is going to drive me a little bit crazy, because how am I ever going to figure out what's going on here? All right, but we come to the point. Exercise is good for you. Turns out, so that when we talk about the left ventricular dysfunction and the aortic stiffness, I can decrease aortic stiffness, I can improve left ventricular function. Okay, exercise is good for you. In the skeletal muscle, I can show you that the VO2 peak will increase, all right? And I can show you that the mitochondrial function will improve, and anaerobic glycolysis is just flux through just because people happen to have diabetes. So I have absolutely failed so far in coming up with a simplification of this model. And this is going to make you crazy, because the entire exercise literature, if this study looks at glucose control, they might show improved glucose control. If this study looks at hypertension, they might show improved hypertension. If this study looks at muscle mitochondrial function, they might show an improvement there. But when you try to put it together in a single model, we're not there yet. So, still a diabetologist, and we want to come after some common threads. And the common threads would be diabetes, hyperglycemia, and endothelial dysfunction. So, what is it about diabetes? Well, you have both hyperglycemia and insulin resistance in diabetes. So, we have a collaborator that had been looking a lot at how insulin would actually regulate blood flow. And I'm going to actually go to this next slide before that first slide. Okay, so insulin, after a meal, okay, we eat this sandwich that has been so generously provided to us. Our insulin levels go up. Insulin acts on the blood vessel to send that elevation in glucose to the skeletal muscle and to the heart. I'm going to store that glucose. Insulin is promoting its own delivery. So in the situation of insulin promoting its own delivery, all right, I'm going to be able to target nitric oxide synthase. And what we know, or what I told you earlier, but now I'm going to show you data so you would believe me, is that nitric oxide synthase does not work very well in animals. And I'm not going to show you the people with diabetes. So if I take a lean mouse and I give it insulin, I will improve the blood flow to the skeletal muscle and the heart. If I take an obese mouse, similar to what we saw in the hearts of our women with premenopausal women with diabetes, we don't see a big insulin response. So now our question in this clinical trial is to see if exercise training will improve insulin, microvascular insulin responsiveness. Okay, so that's that study. All right. And we are now with our MRI friends doing this crazy thing where I can not just do near-infrared spectroscopy, I can measure the specific area where I'm measuring that mitochondrial function. I can look at the blood flow to that. I can look at the perfusion of the artery, and I can look at the oxygen extraction, okay? So working on a campus with people who could do things I could never imagine, a bunch of biomedical engineers who come up with this in vivo oxidative flux, in vivo oxygen extraction, allows me to ask a question in a human person living with or without diabetes of the question that the mechanism I'm trying to get after. So what else are we working on? Well, we have just written a grant on something that is a little bit crazy. Okay, it's called inspiratory muscle strength training. And I meant to have the little thing. It just basically looks like an inhaler. Okay, if I ask you to inhale 6 times a day, six times, and then relax, and then 6 times and relax, and do that for 30 inhalations against a pressure that's 70% of my maximal inspiratory pressure. Do you think that's going to change much of anything? Well, I would say it's really surprising. Okay, so here's the guy. He's doing this inspirometer, and he's doing it a few times a day. And if I do this in elderly subjects, or if Dan Craighead up in Boulder does this in elderly subjects for 5 minutes a day for 6 weeks, crazy. This particular study was 8 weeks. I will improve my flow-mediated vasodilatation measured by a cuff. And if I do, just stick a little catheter in, twirl it around. This is for you, Ethan. Twirl it around, look at the endothelial cells. I will improve the health of those endothelial cells. I'll improve their nitric oxide synthase. I'll decrease their reactive oxygen stress. But relevant to the important issue at hand, I will improve their 6-minute walking distance. I will improve their likelihood to be physically active and the strength of their quad. This is 6 to 8 weeks of inhaling 5 minutes a day. You know, maybe we could get at this, all right? Maybe I can convince people to do this. All right, now, sorry, for those of you who have stayed this long, and if you need to go get back to your patient, I understand. I'm showing you mice. This Richard Benninger is an investigator over at the Barbara Davis Center, and he has created a mouse that you can make acutely hyperglycemic by knocking out glucokinase. Go back to biochemistry. That's the entry point into the islet, glucokinase in the islet. So these animals have not been exposed to any toxin to become hyperglycemic, and they've become acutely hyperglycemic. And we look at them for hyperglycemia, and we see how well can they exercise, what happens to their skeletal muscle. And what I'm going to tell you, our idea is just how much of this is hyperglycemia per se driving the phenotype we're interested in. And what we see in terms of, and this is mitochondrial respiration measured by an oximeter, what we see is just 2 weeks, and this is enough animals to really believe it. 2 weeks, we see decreased mitochondrial respiration. I could show you a bunch more data, but I understand this is medical grand rounds. So I'm just going to tell you how I want to fix this problem. I want to give nitrite. What the heck? Not nitroglycerin, but nitrite. Okay, so why would this work? Okay, if maybe I have convinced you that perfusion is heterogeneous in the skeletal muscle. So in these areas, I've got lots of deoxyhemoglobin. And deoxyhemoglobin is going to take NO2 and turn it to NO, okay? I've got a local reductant there in order to allow me to deliver the nitric oxide right where it's needed, as opposed to giving sublingual nitro, which I can do, or sildenafil, which I can do, but it doesn't work it can work acutely, it doesn't work in the long run, because I'm just willy-nilly perfusing something that may or may not be demanding that perfusion. And what we saw with the nitrite in this hyperglycemic model was that if you weren't hyperglycemic, it was actually somewhat bad for you. But if you were hyperglycemic, and this is not yet ready for prime time, there's at least a signal that it might actually improve function. So my entire point of telling you this translational research story was to tell you that if you're answering important question, decreased functional exercise capacity in people living with otherwise uncomplicated diabetes, and if you're somewhat relentless and willing to undergo, a lot of rejection of papers and grants, etc., over a time, you can have the opportunity to answer a big, hairy, important question and really change the way that we as physicians think about an important clinical problem. So the final story is that diabetes decreases eNOS and insulin action, and that correlates with decreased functional capacity. Exercise can improve these things, but we still maybe have some other things to interrogate, such as how much of it is just the endothelial function. How much is that little teaser I gave you about autonomic dysfunction fitting in here? And is that really why IMST is actually working? Is that really autonomic and not necessarily endothelial, even though it does both? And so as a physician, every time that you see a patient with a problem, you should be approaching it as a hypothesis. You might call it a differential diagnosis, but it's a hypothesis. I think this patient has this. What are the data that I need in order to prove or disprove my hypothesis? Or, you never prove a hypothesis. And then what should I do about it? All right, so I thank you so much for being willing to spend this 45 minutes with me. I want to tell you once again, I didn't do any of this. My team did it all. And the patients, I can't believe what they are willing to do as volunteers. And I can never finish anything without acknowledging my closest collaborator, Dr. Judy Regensteiner, and my incredible mentor in all of this crazy life I've had for the last few decades, Boris Strasman. So thank you.
Thank you so much. We'll throw it open to the room for questions.
Are you a resident? I mean, you were my intern in clinic in the ICU.
Yes, thank you very much, my resident. That was really wonderful. And I just want to let people know that actually Dr. Reusch just finished giving endocrine glands rounds this morning at 8 o'clock. And my question is somewhat related to that. There you were talking about diabetes and treatment of the glucose, of hypertension, of cholesterol, things like that. And listening to this with the perfusion story, with the cardiac story, with the stiffness and the endothelial story, we put people on blood pressure, many of these people on blood pressure medicines. With what you're looking at, especially for exercise capacity and all these things that are getting in the way, do you think about blood pressure medicines that may adversely or proactively affect it while you're doing this?
Yes, and you know, I know it's just sort of going along with the crowd, but SGLT2 inhibitors, and we had a grant that was almost funded on this, but somebody had a grant that actually did get funded on this, and they have demonstrated an improvement of functional exercise capacity with SGLT2 inhibitors. When we think about other things that increase vascular tone, this is when we really, from a cardiac perspective, need to separate out blood pressure from arterial stiffness, because they're not exactly the same thing. And so I can lower blood pressure, but I might still have that stiff, non-compliant heart, non-compliant vessel for the whole system to be dealing with. And so that's where exercise comes in, and some other interventions, maybe even this IMST, which you can actually do IMST with rodents. I don't know how you do it, but it's kind of crazy. And they have arterial stiffness improvements with that. So I think about all of the different things that we're doing to treat diabetes and how they may be colluding to make this problem worse or better.
Ernest?
Thank you, Jane. And for the record, I wasn't checking my watch. I was checking my mitochondria.
Oh, that's so cool. You can do that? Yeah.
So,
Okay. Okay.
So thanks for a terrific talk. I'm going to ask you to put on your crystal ball and take all this work you've done and project us clinicians out 5 or 10 years. What will we be doing differently in terms of primary prevention and the care of diabetes in response to these understandings of
right? So I believe that first off, right now, the best we have is really not, like a butter knife. And hey, everybody, you should exercise 30 minutes a day. And we have no evidence that that's the right amount of exercise. That's just the amount of exercise that has been studied. Okay, so first, I would want to have people incorporating, a quick walk in the clinic, and you can do a walking speed that way. Some maybe an SPPP, some sit to stand timing. Those things can be done in the clinic. Okay, and we think about them in geriatrics. We've got our front row geriatrician there, thinking about that. But I think that we really need some tool to identify if what we're asking somebody to do has actually helped them. So when Brian and I were starting, pulse oxes were only for the ICU. People weren't like having them at home to see if there was, some problem, right? So I think that we may be able to measure this muscle deoxygenation or some other surrogate of the response to the like if I have Mrs. Smith exercising, then I want to know if she's getting a bang for her buck. If she's not, maybe I need to add in a little resistance. Maybe I need to do HIIT therapy. Maybe she needs IMST combined with something. And we have to be, given the potency of the benefit of functional capacity on clinical outcomes, the fact that we're not approaching it scientifically makes no sense. So we need to measure it in the clinic, and we're not going to do a VO2 peak on everybody. Okay, so we need to have some surrogate measures, 100-meter walk, whatever you can lay out in your clinic I mean, at the VA, I go and get my own patients from the waiting room, right? So I go and I'm already doing a functional assessment as they walk incredibly slowly to the clinic room. All right, so I've already got a bit of a sense of that, but we need to be asking about it. And just like a cardiologist will say, how do you feel when you walk up 3 flights of stairs? I might ask the question, do you ever walk up 3 flights of stairs? Right? And so we, you know, like we've gotten really good because we finally have obesity drugs that work at starting to ask for permission and talk to people about what they eat. We need to really talk to them about how much they move. And I need to not kill myself trying to get them to follow an exercise prescription that might or might not work for them. So I need to be able to measure that. So I think the next big thing is for Amy Hipsman to help me figure out how to put into clinic, how to measure exercise capacity, put it into a clinic flow. But thank you for that question because it's really the most important question.
Dr. Jordan.
Dr. Reusch, thanks for a wonderful presentation. So one of the things that basic science has taught us is that all of our intracellular organelles like mitochondria can very substantially remodel in the context of a variety of different disease states. So you implied in your presentation that diabetes might in fact be a mitochondrial disease. Have you looked directly at the structure of mitochondria in normal versus diseased people?
Yeah, it's our gig. Yeah, we have. So more so in the animal models. So we will see sort of smaller, you know, and presumably, so we've looked at endothelial cells specifically in culture, injured them with hyperglycemia. We see small punctate mitochondria, not our beautiful lacy mitochondrial networks that we usually see. I mean, nobody guesses that this big lacy network is a mitochondria. They're like, well, it's a, but they'll get very punctate in the context of hyperglycemia. In the skeletal muscle, we've measured their respiration. We've looked at their structure, and more so even their localization. But it is really tough to do on any histology because you can do EM, and we have, but electron microscopy gives you, you know, such a little sample, you don't know what's real, right? And so but what we can do is measure mitochondrial dynamics, or at least markers of mitochondrial dynamics. In an animal, we can do that with MitoTracker, and we've identified that females have a much greater mitophagy, which is autophagy of the mitochondria, in response to high nutrient stress than males. And so that means that they're able to remodel and clean up and recycle for parts better than the other mitochondria. Okay, but we've also measured fission and fusion with, you know, sort of good biomarkers. You can publish the heck out of them, but whether they tell me exactly what's happening, that's why we usually do a composite. I've got mitochondrial content by protein, mitochondrial content by mitochondrial DNA. I've got mitochondrial respiration and some structural assets, you know, put it all together to try to figure out what's going on with those mitochondria.
I'm going to take that for a yes. It's a mitochondrial disease. I'm kidding.
I'm going to say though, if we go back to my biopsy, it was the mitochondria were not that puny. I had a little bit of decreased mitochondrial biogenesis. I had slightly lower, but not statistically lower respiration. They are not that bad. And if you go across, then that's the heterogeneity of diabetes. But if you go across populations, all these studies, like I do, they're small physiological studies. I can't say what really is going on, because I can find a paper to support anything I want. No or yes. Sorry about that long answer.
What do you know about diabetics? I'm going to use this term loosely, who've gotten better, but what, you know, I mean, we can medically manage some people with diabetes. What about those who are surgically managed? Do we know anything about people who have this condition very overtly? They have an intervention, and then over time they have either less of or none of that condition.
Okay, so diabetes remission is what you're talking about. So with bariatric surgery, we can see a fair amount of diabetes remission. What diabetes remission is defined as, but it still remains controversial, is 6 months of not requiring diabetes medicines with an A1C in the normal glycemic range, not pre-diabetes. That's remission. We are currently with Kristen Nadeau and her group studying the cardiac and vascular response post-bariatric surgery as well as the renal response. We have N of 4 looking pretty good. Looks like something is actually happening, but you know, that's N of 4. There is, you know, diabetes isn't for everyone. So if you don't have the wrong parents, it's pretty hard to get diabetes, even if you have a BMI of 45. All right, so there's really a strong genetic component, and we have to keep that in mind. And that's why people like to study animals, but the minute I can, I'll always move to humans.